So by this point, you're probably aware that your body needs oxygen to survive, right? In fact, every cell in your body needs that precious oxygen. Those cells use the oxygen to produce energy in the form of ATP, or adenosine triphosphate, a super, super important molecule, sometimes even called the molecular unit of currency. The cells use it to basically pay the molecules inside the cell to do their specific jobs. It's like one big factory with a bunch of workers that all have specific jobs needed to run the factory, and they only take ATP as payment. Now, the mitochondrion of the cell takes in oxygen and makes ATP to pay the workers through a process called oxidative phosphorylation. So the mitochondrion is like the factory's payroll department, right? When the cell doesn't get enough oxygen, and so payroll can't produce the ATP that they need to pay the workers to do their jobs, the whole cellular factory can be damaged or even die. And we call that process hypoxia, where hypo means less than normal, and oxia means oxygenation. When the oxygen comes in, typically it goes straight to payroll, specifically to the inner mitochondrial membrane, where oxidative phosphorylation takes place. Oxygen is used in one of the last steps and serves as an electron acceptor, and this allows the process to finish and produce ATP. So without oxygen, we can't finish oxidative phosphorylation and produce ATP. But why does the whole factory fall apart when payroll stops making ATP? Why don't they just pause for a bit or take a little break? Well, when certain workers stop doing their jobs, things get a little out of hand. One super important worker is the sodium-potassium pump on the cell's membrane. Pretty much like the bouncer that makes sure there isn't too much sodium diffusing into the cell, basically by pumping it back out every time it diffuses in and maintaining a concentration gradient. This process also keeps too many water molecules from passively diffusing into the cell. Think of it like this. Water molecules want to go every which way and are constantly moving back and forth, inside and outside the cell. But all these sodium ions on this side tend to physically block them from leaving that side. So over time, more water molecules get retained or almost trapped on the side with more sodium. In short, the more sodium molecules, the more water molecules. But our pump doesn't do all this for free, and it needs ATP. So without ATP, it stops pumping sodium back out, and sodium starts to diffuse in. And it keeps diffusing in, and the concentration gradient goes away. Now, with less sodium molecules in the outside blocking the water molecules from going into the cell, water follows the sodium in, which causes the cell to swell up. And when the cell swells up, a couple things start to happen. First, usually you have these really tiny microvilli on the cell's membrane, which sort of look like little fingers that help increase the cell's surface area and therefore help the cell absorb more things. When the cell swells up and gets all bloated, the water sort of fills these little fingers and reduces the surface area, which makes it harder to absorb molecules since there's less surface area, right? Also, sort of along the same lines, the cell can bleb, or bulge outward from all this water. And this is a sign that the cell's cytoskeleton, or this structural framework, is beginning to fail, and is letting water slip through. Finally, the rough endoplasmic reticulum, or the rough ER, also swells when the cell swells. And remember that the rough ER has all these little ribosomes on its outside, and these are really important for the cell in making proteins. But when the rough ER swells, they detach and stop making proteins, so protein synthesis goes down. All the ATP isn't immediately lost, though, when you lose oxygen and oxidative phosphorylation stops. Luckily, your cell can make ATP another way, called anaerobic glycolysis. Anaerobic meaning in the absence of oxygen.
This is like the backup ATP generator, which isn't nearly as efficient and only produces a net of about 2 ATP molecules per glucose, whereas oxidative phosphorylation makes about 30 to 36.
So it helps a little, but what also happens is it produces a byproduct called lactic acid, which lowers the pH inside the cell. This more acidic environment can denature or essentially destroy proteins and enzymes. Now, up to this point, it's not all bad, because one super important thing about these processes that happen to the cell is that they're potentially reversible, meaning that if we all of a sudden get oxygen again and start making ATP, then these changes aren't necessarily permanent. After enough time, though, irreversible damage can happen to the cell. Kind of like the sodium-potassium pump, there's also a calcium pump that helps keep too much calcium from getting in. And if that stops working, then calcium starts to build up, which is not a great thing. First, calcium can activate certain enzymes that you might not necessarily want to activate, like proteases that can slice up proteins and damage the cell's cytoskeleton, which remember is the structural framework that keeps the cell together. Also, endonucleases can be activated, which can cut up DNA, the cell's genetic material. And if we get back to the lactic acid, as more lactic acid builds up and the environment gets more acidic, the lysosomal membrane can be damaged as well, which usually houses these hydrolytic enzymes whose job is basically to grind up large molecules. And when they get out, well, they're also activated by calcium, and then they just start cutting everything in sight, and basically start digesting the cell from the inside. Finally, the phospholipase enzyme, which basically splits phospholipids, gets activated. Since the cell's membrane's made of phospholipids, these can destroy the cell membrane, which is probably the most important sign of irreversible damage. When the membrane's destroyed, these enzymes we just listed, along with others, can leak out into the blood and continue wreaking havoc. Finally, let's jump back to calcium. Enzyme activation isn't the only effect calcium can have. Calcium can actually get into the mitochondria, causing a cascade that leads the mitochondrial membrane to be more permeable to small molecules. And so it lets a molecule that usually stays in the mitochondria, cytochrome C, to leak out into the cytosol. And this is a big red flag to the cell that things have gone south, and is kind of analogous to the self-destruct button, and activates a process called apoptosis, or programmed cell death. And this is a bit like cellular suicide. At this point, the cell's not in good shape, right? And all this happened eventually because of a lack of oxygen, or because of hypoxia.
Inflammation classically describes 4 key signs, each of which have a Latin derivation: calor or heat, dolor or pain, rubor or redness, and tumor or swelling. Sometimes these 4 signs combine to cause a 5th sign, which is functio lysa, or temporary loss of function due to pain or swelling. Alright, so inflammation usually starts with some stimuli, like a pathogen. Now, even though pathogens are a common cause of infection which can lead to inflammation, inflammation can be caused by other things as well, like toxins and trauma. For example, after an intense workout, your muscles might feel sore. That's due to inflammation trying to repair your overused muscle fibers. Ultimately, the goal of inflammation is to respond to the stimuli and restore balance. Oftentimes, that includes eliminating the cause of tissue injury, clearing out necrotic or dead cells, and starting tissue repair. Broadly speaking, inflammation can be triggered by external and internal factors. External factors can be non-microbial or microbial. Non-microbial factors include allergens, irritants, and toxic compounds. Now, the 2 main microbial factors that trigger inflammation are virulence factors and pathogen-associated molecular patterns, or PAMPs. Virulence factors are molecules that help pathogens colonize tissues and cause infection. PAMPs are small molecules with conserved patterns that are shared across many different pathogens, including bacterial wall components like peptidoglycan, lipopolysaccharide or LPS, and lipoteichoic acid, and fungal wall components like mannan. For intracellular pathogens like viruses, PAMPs might include the viral RNA or DNA. Our immune system recognizes virulence factors and PAMPs as foreign substances, and can trigger an inflammatory response against them. Now, in terms of internal factors, it turns out that there's an endogenous equivalent to PAMPs called damage-associated molecular patterns, or DAMPs. DAMPs are intracellular proteins that get released when a cell's plasma membrane is injured, or when a cell dies. So DAMPs are a signal that there's serious cell damage, and they trigger inflammation. Now, PAMPs and DAMPs are recognized by pattern recognition receptors, or PRRs, which are cell surface receptors on various leukocytes that help to activate those cells and spark the inflammatory response, which can be thought of as the innate immune system. Key features are that this response is nonspecific, meaning that PRRs don't distinguish one specific pathogen from another, although they can distinguish between broad categories like viruses from bacteria. Also, the response is super fast, occurring within minutes to hours. And finally, there's no memory associated with innate responses. Generally speaking, there are two main types of leukocytes: granulocytes, which include neutrophils, eosinophils, basophils, and mast cells, and agranulocytes, which include lymphocytes and monocytes, which can differentiate into macrophages or dendritic cells. The inflammatory process usually starts with either macrophages or mast cells, both of which are found in the tissues. When there's tissue damage, these cells respond to the PAMPs or DAMPs. Mast cells have granules containing different inflammatory mediators, like histamine, serotonin, cytokines, and eicosanoids, like prostaglandins and leukotrienes. These inflammatory mediators act on the endothelial cells surrounding the capillaries nearby, causing them to separate from each other. In addition, macrophages, which are the garbage truck of the body, start to eat up invading pathogens. The release of cytokines causes capillaries to get larger and increase vascular permeability, allowing plasma proteins and fluids to leave the circulation. Endothelial cells also help spur on this process by releasing nitric oxide, which helps vasodilate the capillaries and makes them more permeable. In addition, endothelial cells express more adhesion proteins to help leukocytes that are floating by in the blood to attach and roll along the vessel wall until they reach the injured site. In particular, neutrophils get attracted to the site of infection by the chemokines and microbial products. The neutrophil then starts to squeeze through the gaps between two endothelial cells until it reaches the other side, and this is called extravasation. It's kind of like squeezing between two fence poles to sneak into an amusement park, rather than paying admission. But that's not to say you should do that. Now, next, the leukocyte follows a gradient of inflammatory mediators to get to the site of inflammation. Neutrophils are the first leukocytes recruited during the acute inflammatory process, and they're like hungry athletes. They immediately start phagocytosing or eating pathogens and damaged cells. Neutrophils take in a lot of pathogens quickly, kind of like a vacuum, and then undergo apoptosis, destroying themselves and all of the pathogens they've taken in. Now, while this is all happening, there's also a family of soluble proteins called the complement system. The complement proteins most often get activated in the presence of antibodies bound to pathogens, or by molecules on the pathogens. Once these complement proteins are active, they help attract leukocytes, and help with opsonization, meaning that they can bind to microbes so that leukocytes can more easily phagocytose them. Kind of like sticking a fork in a meatball so that it doesn't slip away. Some of the complement proteins also kill pathogens by directly forming a channel in their membrane, literally punching a hole in it. All the while, dendritic cells continue to phagocytose pathogens and present bits of them to T lymphocytes. This activates the adaptive immune system, which kicks in after a few days. If the stimulus for all of this inflammation was a cut or a scrape, then platelets and clotting factors from the plasma reach the area and clot the wound. This helps stop the bleeding, as well as prevents pathogens from entering the bloodstream, and provides a framework for tissue repair. In summary, all of these factors contribute to the heat, pain, redness, and swelling that's classic for inflammation. Now, the inflammatory response ends with tissue repair. Macrophages are recruited to eat up dead and dying cells, so that when tissue can make room for new cells, this is followed by angiogenesis, which is the formation of new blood vessels. And that's triggered by growth factors released by macrophages. These newly formed blood vessels are temporary, meaning that once the wound is healed, these new vessels regress. Finally, there are fibroblasts, which come into the area of inflammation and synthesize collagen to help with wound healing. Overall, if there's only mild damage, then the tissue regenerates back to its normal healthy state. But if there's severe damage, then the damaged cells get replaced by a non-functional fibrous scar. Alright, as a quick recap. Inflammation is a complex response to harmful stimuli, which could be from a pathogen, but it also could be from trauma or toxins. The response involves blood vessels dilating and becoming more permeable, and attracting more immune cells and fluid into the local tissue. The classical signs of inflammation are heat, pain, redness, and swelling, and these can lead to a loss of function. The inflammatory response ends with wound repair and resolution, either restoring the initial tissue integrity or leaving a fibrous scar.
Hypoxia, or lack of oxygen in cells and tissue, can happen in a number of ways, and ischemia is one of them. Ischo means restraint or suppression, and emia refers to the blood, so ischemia must mean some kind of suppression or reduction of blood flow to an organ or tissue. And blood carries oxygen, right? So when there's a reduction in blood flow to cells, that also means there's a reduction of oxygen to those cells, and this is due to the lowered blood flow in the blood vessels. This lowered flow could be from something blocking the blood from the inside, or it could be something compressing the blood vessel from the outside. An example of something blocking the vessel from the inside is a thrombus, also known as a blood clot. These are solid clumps of platelets and fibrin that obstruct blood flow. Ischemia resulting from something outside the blood vessel is traumatic injury, which can cause inflammation and swelling that physically applies external pressure to the blood vessel, compresses it, and restricts blood flow. Alright, so let's say that this is your artery, and it's like the one-way highway leading all these red blood cells into the city, which is like a major organ in the middle here. So maybe this is Organopolis. These red blood cells are super pumped for their day, where they can drive around the capillaries, like the smaller city streets, and supply the city with fresh oxygen and pick up waste. And this Organopolis is made up of thousands of cells, like homes, that use up the oxygen and create waste that needs to be picked up. The deoxygenated blood cells drain out through different small streets, which are the veins, and go back towards the heart. So one way this organ city could become ischemic is if there's some obstruction to arterial flow into the tissue. Now only a few red blood cells can get in at a time. You might imagine that Organopolis sees a lot less blood and a lot less oxygen, and becomes ischemic. A super important and well-known example of this arterial ischemia is atherosclerosis, where plaque builds up in the arteries going to your heart tissue, which blocks arterial flow, reduces the amount of blood and oxygen that makes it to your heart tissue, and causes ischemic heart disease. Since you can have a blockage of red blood cells coming in, you can also have a blockage of red blood cells going out, leading to a decrease in blood drainage on the venous side. So in this case, you've got a major obstruction in the venous highway leaving the city. So say that these are like the veins draining blood out of Organopolis. All these workers are getting into Organopolis, but they can't leave because there's this blockage heading out, and traffic gets majorly backed up, causing flow to slow down throughout the whole city. This again leads to less oxygen to the tissues and ischemia. Thinking about an organ, it might get so congested that pressure can rise, causing fluid to get forced out of the blood vessels and into the tissues, generating edema. This whole example is very similar to Budd-Chiari syndrome, where the hepatic veins that drain blood out of the liver are blocked by a thrombosis, or a clot. And now blood can't flow through the liver, and the liver tissue becomes ischemic and can lead to liver edema and hepatomegaly, or enlargement of the liver. If the oxygen supply is low enough for long enough, it can cause cell death, And if enough cells die in a region of tissue, we would call that tissue necrosis and infarction. In some cases, there are areas of tissue that are getting close to infarction as cells begin to die off, but they're still able to get saved if they receive blood. This high-risk area that's teetering on the brink of death is called the ischemic penumbra. In some cases, there are two arteries serving a single area of tissue. And this goes against how we often think about tissue as being served by a single capillary bed from a single artery. But when you think about it in 3 dimensions, there can be a lot of overlap, right? If there are these secondary or collateral arteries going to the area, then there might be enough blood flow to keep the penumbra alive for a while. Over the course of weeks to months, these secondary arteries can even grow in size to bring more blood to that area, a bit like disaster relief. This process is called collateralization. So if blood flow to an organ is blocked all of a sudden, a super important concept to keep in mind is called time to reperfusion. This refers to the importance of reestablishing perfusion to the affected organ before the cells die and the ischemia becomes irreversible. Remember that perfusion and blood flow are slightly different. Blood flow is the volume of blood flowing per unit time, like liters per minute. Perfusion is like a measurement of how much blood is flowing to a chunk of tissue per time. So it might be given in liters per minute per gram of tissue. So as an example, if you compared the total blood flow to the kidneys with the total blood flow to the liver, it'd be higher to the liver because the liver is a lot larger. But if you took a 10-gram cube of liver tissue and compared it to a 10-gram cube of kidney tissue, the kidney actually has higher perfusion, since it has more blood vessels packed into its cube. Now, back to reperfusion. If perfusion to the area is reestablished quickly enough, then it's possible that the ischemia is reversible because the cells were dying, but they're not dead. If too much time has passed and the cells have actually died, then the ischemia is irreversible since you can't bring back dead cells. One example of irreversible ischemic damage is something like a heart attack or a myocardial infarction, where an artery supplying a specific part of the heart with blood becomes blocked, causing death of that part. Depending on the area that's affected, this could cause serious heart dysfunction. Like if enough of the heart's ventricle was damaged, it might not be able to pump blood as well anymore.
Sickle cell disease, also called sickle cell anemia or just sickle cell, is a genetic disease where red blood cells can take the shape of a crescent or sickle, and that change allows them to more easily be destroyed, causing anemia, among other things. Sickle cell disease is caused by defective hemoglobin, which is the oxygen-carrying protein in red blood cells. Hemoglobin is actually made up of 4 peptide chains, each bound to a heme group. Different hemoglobins have different combinations of these chains. Hemoglobin A, or HbA, is made up of 2 alpha globin and 2 beta globin peptide chains. And this is the primary hemoglobin affected in sickle cell. Specifically, the beta globin chains end up misshapen. This is because of a mutation in the beta globin gene, or HBB gene. Sickle cell is an autosomal recessive disease, so a mutation in both copies of the beta globin gene is needed to get the disease. If the person has just one copy of the mutation and one normal HBB gene, then they're a sickle cell carrier, also called sickle trait. Having sickle trait does not cause health problems unless the person is exposed to extreme conditions, like high altitude or dehydration, where some sickle cell disease-like symptoms can crop up. What it does do is decrease the severity of infection by Plasmodium falciparum malaria. So in parts of the world with a high malaria burden, like Africa and pockets of southern Asia, those with sickle trait actually have an evolutionary advantage. This phenomenon is called heterozygote advantage, and its unfortunate consequence is a high rate of sickle cell disease in people from these parts of the world. Almost always, the sickle cell mutation is a non-conservative missense mutation that happens in the 6th amino acid of beta-globin being a valine instead of glutamic acid. A non-conservative substitution means that the new amino acid, or valine, which is hydrophobic, has different properties than the one it replaced, glutamic acid, which was hydrophilic. A hemoglobin tetramer with 2 alpha globin and 2 mutated beta globin proteins is called sickle hemoglobin, or HbS. HbS carries oxygen perfectly well, but when deoxygenated, HbS changes its shape, which allows it to aggregate with other HbS proteins and form long polymers that distort the red blood cell into a crescent shape, a process called sickling. Conditions favorable for sickling include acidosis, which decreases hemoglobin's affinity for oxygen, and small, low-flow vessels where red blood cells' hemoglobin molecules have plenty of time to dump lots of oxygen molecules. Repeated sickling of red blood cells damages their cell membranes and promotes premature destruction. Since this happens within the vasculature, it's called intravascular hemolysis. This destruction of red blood cells not only leads to anemia, which is a deficiency in red blood cells or loss of the normal levels of hemoglobin, but also means a lot of hemoglobin spilling out. Free hemoglobin in the plasma is bound by a molecule called haptoglobin and gets recycled, which is why a low haptoglobin level is a sign of intravascular hemolysis. Recycling of that heme group yields unconjugated bilirubin, which at high concentration could cause scleral icterus, jaundice, and bilirubin gallstones. To counteract the anemia of sickle cell disease, the bone marrow makes increased numbers of reticulocytes, which are immature red blood cells. This ends up causing new bone formation, and the medullary cavities of the skull can expand outward, which causes enlarged cheeks and a hair-on-end appearance on skull X-ray. Extramedullary hematopoiesis, which is red blood cell production outside of the bone marrow, can also happen, most often in the liver, which can cause hepatomegaly. In sickled form, red blood cells tend to get stuck in capillaries, called vasoocclusion. Starting in infancy, they can clog up blood flow in the bones of the hands and the feet, causing dactylitis, or swelling and pain of the digits. Later, they get stuck in other bones, causing a sickle cell pain crisis, or avascular necrosis of the bone. Red blood cells can also clog up the spleen, which can lead to an infarct of the spleen as well as an enormous backup of blood in the spleen, called splenic sequestration, a life-threatening complication. Over time, splenic infarcts can lead to autosplenectomy, where the spleen scars down in fibrosis to basically nothing. Having an absent or non-functional spleen makes a person susceptible to encapsulated bacteria, like Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitidis, and Salmonella species. Since encapsulated bacteria are normally opsonized and phagocytized by macrophages in the spleen. It also leaves a person with Howell-Jolly bodies, which are basophilic nuclear remnants in red blood cells, which can be seen on a peripheral blood smear. Sickled red blood cells can get stuck in the cerebral vasculature, causing vessel damage resulting in strokes. Extensive sickle cell damage to the brain vessels may result in moya-moya disease, which is named for the puff of smoke collateral vessels that bypass blocked arteries. They can also get stuck in the blood vessels of the lungs, leading to acute chest syndrome. This is particularly dangerous because it sets up a vicious cycle of congested, deoxygenated red blood cells preventing other red blood cells from getting oxygen. And this is made worse by the lung's natural tendency for hypoxic vasoconstriction, which is blood vessel constriction in areas of the lungs that are low in oxygen. In addition, clogging in the renal papillae can cause necrosis, which can manifest as hematuria and proteinuria, blood and protein spilling out into the urine. And in men, clogging of the vasculature of the penis can cause priapism, a painful and prolonged erection. Given all of these symptoms, it's important to diagnose sickle cell as early as possible, so it's included in the newborn blood spot screen in some countries, and can also be identified with a blood smear looking for sickled cells or by identifying HbS using protein electrophoresis. The factors that cause red blood cells to sickle, which are hypoxia, dehydration, and/or acidosis, can be improved with oxygen and fluids, which are mainstays of treatment. In addition, opioids are usually used to manage pain, and antibiotics are used to treat any underlying bacterial infections, causing acute chest syndrome. Occasionally, blood transfusions are also used, but the risk of multiple transfusions include iron overload and the risk of developing new antibodies against future blood transfusions. Finally, children with sickle cell typically get prophylaxis with penicillin and an additional polysaccharide vaccine against Streptococcus pneumoniae to help prevent sepsis and meningitis with encapsulated bacteria. Another preventative medicine is hydroxyurea, which works by increasing the amount of gamma globin, which results in more fetal hemoglobin, or HbF. Fetal hemoglobin is made up of 2 alpha and 2 gamma globin chains, so it does not include the mutated beta globins. Since it cannot polymerize, it gets in the way of HbS polymers being made and prevents sickling. HbF is the primary hemoglobin at birth, which explains why sickle cell symptoms don't happen until a few months of life, when adult hemoglobin starts to predominate, which contains the mutated beta globin. More rarely, bone marrow transplants have been used in some patients, and given that sickle cell involves a single point mutation, gene therapy is another option being researched. Alright, as a quick recap, sickle cell disease is an autosomal recessive genetic disease where the beta globin subunit of hemoglobin is misshapen, which causes red blood cells to sickle when deoxygenated, and this leads to their premature destruction as well as vasoocclusion. Furthermore, multi-organ damage is the end result from ongoing sickling and hypoxic damage to the body's important organs, resulting in a shortened lifespan. The word hemophilia is a combination of the Greek words for blood and love, a way of saying that people with hemophilia love to bleed, or rather that it's hard to stop bleeding. This is because the process called hemostasis, literally meaning to stop the flow of blood, is impaired. Normally, after a cut and damage to the endothelium, or the inner lining of blood vessel walls, there's an immediate vasoconstriction or narrowing of the blood vessel, which limits the amount of blood flow. After that, some platelets adhere to the damaged vessel wall and become activated, and then recruit additional platelets to form a plug. The formation of the platelet plug is called primary hemostasis. After that, the coagulation cascade is activated. First off, in the blood there's a set of clotting factors, most of which are proteins synthesized by the liver, and usually these are inactive and just floating around in the blood. The coagulation cascade starts when one of these proteins gets proteolytically cleaved. This active protein then proteolytically cleaves and activates the next clotting factor, and so on. This cascade has a huge degree of amplification, and takes only a few minutes from injury to clot formation. The final step is activation of the protein fibrinogen to fibrin, which deposits and polymerizes to form a mesh around the platelets. So these steps leading up to fibrin reinforcement of the platelet plug make up the process called secondary hemostasis, and results in a hard clot at the site of the injury. In most cases of hemophilia, there's a decrease in the amount or function of one or more clotting factors, which makes secondary hemostasis less effective and allows more bleeding to happen. Now, that coagulation cascade can get started in 2 ways. The first way is called the extrinsic pathway, which starts when tissue factor gets exposed by the injury of the endothelium. Tissue factor turns inactive factor 7 into activated factor 7A, A for active. And then tissue factor goes on to bind the newly formed factor 7A to form a complex that turns factor 10 into active factor 10A. Factor 10A, with factor 5A as a cofactor, turns factor 2, which is also called prothrombin, into factor 2A, also called thrombin. Thrombin then turns factor 1, or fibrinogen, which is soluble, into factor 1A, or fibrin, which is insoluble and precipitates out of the blood at the site of the injury. Thrombin also turns factor 13 into factor 13A, which cross-links with fibrin to form a stable clot. The second way is called the intrinsic pathway, and it starts when platelets near the blood vessel injury activate factor 12 into factor 12A, which then activates factor 11 to factor 11A, which then activates factor 9 to factor 9A, and factor 9A along with factor 8A work together to activate factor 10 to factor 10A. And from that point, it follows the same fate as before. So both the extrinsic and intrinsic pathways basically converge on a single final path called the common pathway. Believe it or not, this is a somewhat simplified version of the coagulation cascade, but it has all the key parts needed to understand hemophilia. Now, an insufficient concentration or decreased activity of any coagulation factor can cause hemophilia, except factor 12 deficiency, which is asymptomatic. Hemophilia usually refers to inherited deficiencies of coagulation factors, which can be either quantitative or qualitative. By far, the most common of these are deficiencies of factor 8, which gives rise to factor 8A and is stabilized by another factor called von Willebrand factor. And this deficiency is called hemophilia A, or classic hemophilia. Another common deficiency is deficiency of factor 9, called hemophilia B, which used to be called Christmas disease, named after the patient who had it, not the holiday. Now, a mimic of hemophilia A is von Willebrand disease, which is an inherited problem with primary hemostasis caused by a deficiency of von Willebrand factor. So in severe von Willebrand deficiency, factor 8 gets broken down faster and can become deficient too. As opposed to inherited forms of hemophilia, one acquired cause of hemophilia is liver failure, since the liver synthesizes factors 1, 2, 5, 7, 8, 9, 10, 11, and 13. Also, vitamin K deficiency can cause hemophilia, since vitamin K is needed by the liver to synthesize and release factors 2, 7, 9, and 10. Another cause is autoimmunity against a clotting factor. And finally, there's disseminated intravascular coagulation, which consumes coagulation factors. Now, the mutated genes in hemophilia A are called F8, and in hemophilia B, they're called F9. And these are both on the X chromosome, meaning both conditions are X-linked recessive. So it usually affects men, since they only have one X chromosome, and therefore only one copy of the F8 and F9 genes. Women with one mutated gene copy have a remaining healthy copy, so they don't get hemophilia, unless X chromosome inactivation turns off the normal copy in the majority of cells. But generally, women are carriers, while men are symptomatic with the disease. Signs and symptoms of hemophilia A and B are nearly clinically identical, which makes sense since factors 8A and 9A work together in the coagulation cascade to activate factor 10. Both of these can cause easy bruising, or ecchymosis, as well as hematomas, which are collections of blood outside the blood vessels that are often deep in the muscles, prolonged bleeding after a cut or surgical procedure, for example circumcision, oozing after tooth extractions, gastrointestinal bleeding, hematuria, which is blood in the urine, severe nosebleeds, and hemarthrosis, or bleeding into joint spaces. A dangerous complication is bleeding into the brain, which can cause a stroke or increased intracranial pressure. Now, the severity of the symptoms depends on the severity of the underlying mutation, which determines the activity of the factor. Diagnosis of hemophilia A and B usually starts with lab tests, including a platelet count, which is usually normal, a prothrombin time, and a partial thromboplastin time. The prothrombin time tests extrinsic and common pathways, which means factors 7, 10, 5, 2, which is prothrombin, and 1, which is fibrinogen. Whereas the partial thromboplastin time tests the intrinsic and common pathways, meaning factors 12, 11, 9, 8, 10, 5, 2, and 1. Since factors 8 and 9 are part of the intrinsic pathway, prothrombin time is normal, and partial thromboplastin time is prolonged in hemophilia A and B. In order to confirm hemophilia A or B, tests to look at specific factor activities and mutation testing of the genes encoding them can be done. Treatment for hemophilia A and B is usually done with injections of the missing or non-functional clotting factor. Unfortunately, if the patient has severe deficiency, where intrinsic production of the factor is absent or very low, these supplemental factors can be seen as foreign by the immune system, which results in the production of antibodies that try to eliminate the injected clotting factors, which are called inhibitors. Inhibitors diminish the treatment's effectiveness over time, and can also sometimes cause anaphylaxis, which is a severe allergic reaction. For hemophilia A, desmopressin, also called DDAVP, is helpful for patients with mild quantitative factor VIII deficiency. Desmopressin stimulates von Willebrand factor release from endothelial cells, which promotes the stabilization of the residual factor VIII. Finally, it's best for individuals with hemophilia to avoid contact sports and medicines that promote bleeding, like aspirin. Alright, as a quick recap. Hemophilia is a bleeding disorder that's caused by an impaired coagulation cascade. Hemophilia A is caused by mutations in the genes for factor VIII, and B is caused by mutations in the genes for factor IX. And these two are the most common genetic hemophilias, and are both treated by supplementing the missing clotting factor. Over 1 billion people around the world have hypertension, or high blood pressure. So that pretty much means it's pretty common. Let's start by defining it. Typically, it's represented by two numbers. The top number is the systolic blood pressure, which is the arterial pressure when the heart's contracting. And the lower number is the diastolic blood pressure, which is the arterial pressure when the heart's relaxing or refilling. Most of the time, blood pressure is taken in the brachial artery in your upper arm. Because if the pressure's high there, it's probably high throughout all of the arteries. The guidelines for categorizing blood pressure have recently changed to reflect a growing body of evidence that shows even moderately high blood pressures can significantly increase your risk for developing heart disease. Now, normal systolic blood pressure is defined as less than 120 millimeters of mercury, and a normal diastolic pressure is less than 80 millimeters of mercury. Elevated systolic blood pressure is considered between 120 and 129 millimeters of mercury, and less than 80 millimeters of mercury on the diastolic side. Stage 1 hypertension is between 130 and 139 millimeters of mercury on the systolic side, and between 80 and 89 millimeters of mercury on the diastolic side. Stage 2 hypertension is defined as anything that's 140 millimeters of mercury or higher on the systolic side, and 90 millimeters of mercury or higher on the diastolic side. Typically, both systolic and diastolic pressures tend to climb or fall together, but that's not always the case. Sometimes you can have systolic or diastolic hypertension, when one number is normal and the other is really high. This is referred to as isolated systolic hypertension or isolated diastolic hypertension. High blood pressure is a serious problem for the blood vessels, because it causes wear and tear on the endothelial cells that line the inside of the blood vessels. Just like a garden hose that's always under higher pressure, in the long term, blood vessels can develop tiny cracks and tears that can lead to serious problems, like myocardial infarctions, aneurysms, and strokes. Now, about 90% of the time, hypertension happens without a clearly identifiable underlying reason, and we call this primary hypertension or essential hypertension. In other words, over time, pressure in the arteries starts to silently creep up. And there are a bunch of risk factors that we've identified for primary hypertension, and these include old age, obesity, salt-heavy diets, and sedentary lifestyles. With the exception of age, all of these can be improved with lifestyle changes, and those changes can help reduce hypertension. About 10% of the time, though, there is a specific, identifiable underlying condition that's the cause of the hypertension, and we call this secondary hypertension. For example, anything that limits the blood flow to the kidneys or the renal blood flow can cause hypertension, as well as things like atherosclerosis, vasculitis, or aortic dissection. This is because the kidneys play a super important role in blood pressure regulation. When not enough blood flows to the kidney secretes the hormone renin, which ultimately helps the kidneys retain more water. That water contributes to more blood in the arteries, making them more full, which leads to higher pressures. Other diseases can also cause secondary hypertension. Fibromuscular dysplasia, which affects young women, can cause the walls of the large and medium-sized arteries to thicken. If it involves the renal artery and limits blood flow to the kidneys, it triggers more renin. Another example is a tumor that produces excess aldosterone, and just like renin, this leads to fluid retention. Finally, if the blood pressure gets really high really fast, it's referred to as hypertensive crisis. It involves a systolic pressure greater than 180 millimeters of mercury or a diastolic pressure greater than 120 millimeters of mercury. Hypertensive crisis can be further split into hypertensive urgency and hypertensive emergency. With hypertensive urgency, there hasn't yet been damage to end organs, like the brain, kidneys, heart, and lungs. In hypertensive emergency, there has been shown to be evidence of damage to end organs. So for symptoms, usually primary hypertension isn't actually accompanied by any symptoms, which is why it's sometimes referred to as a silent killer. Secondary hypertension might involve a variety of symptoms associated with the underlying cause. And finally, hypertensive emergency might involve symptoms like confusion, drowsiness, chest pain, and breathlessness. The first choice for treatment of hypertension is lifestyle changes, like changes to the diet, exercise, and stress reduction techniques. In addition, there are a variety of antihypertensive medications that might be given in some cases as well. Alright, as a quick recap, hypertension or high blood pressure affects over 1 billion people around the world, and over time is a major risk factor for heart disease and stroke. Stage 1 hypertension is defined as 130 to 139 millimeters of mercury for the systolic blood pressure, and between 80 to 89 millimeters of mercury for the diastolic pressure, while stage 2 hypertension is defined as greater than 140 millimeters of mercury on the systolic side and greater than 90 millimeters of mercury on the diastolic side. Hypertension usually doesn't cause any symptoms, and the first line of treatment is lifestyle changes. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
In statistics, it's often helpful to know the central point of a set of data, because